So welcome to Principles of Exercise Prescription. The main learning objectives for this PowerPoint are to define muscle strength and endurance, consider the basic components of the strength and endurance program, manipulate the basic components of the program to develop muscle strength and muscle endurance programs, consider the potential physiological and psychological benefits of strength training, and consider and practice common progressive overload techniques. So exercise is defined in the Oxford English Dictionary as activity requiring physical effort carried out to sustain or improve health and fitness. The UK Physical Activity Guidelines are outlined within the link on here, and it's really worth having a look at the UK Physical Activity Guidelines because it sets out them out for children, for adults, for children with learning disabilities, for those that living with a disability. So you can find lots of different infographics in there that are useful in practice. 5 outcomes of physical well-being so physically inactive adults can cost up to 7.4 billion in the UK each year. Being active can improve fitness, strength and balance, prevent and manage medical conditions, increase energy levels and improve the quality of sleep. Physical activity also reduces the risk of type 2 diabetes, cancer, dementia, strokes, depression and heart disease. So these are really worth investing in long term when we're talking about physical well-being. So why promote physical activity? So by being physically active, you can decrease the risk and the impact of knee arthritis by 47%, reduce the risk of cancer by up to 50%, reduce or reverse the effects of diabetes by up to 58%, reduce anxiety by up to 48%, reduce depression by up to 30%, and reduce the likelihood of premature death by up to 30%, and has a huge increase in the quality of life. So these are the moderate or strong evidence for health benefit looking at children, adults and older adults. So for children, it improves bone health, increases cognitive function, improves cardiovascular fitness and muscle fitness, reduces their weight and reduces the risk of depression. Similarly, in adults, we're looking at reduction in all causes of mortality, stroke and heart disease reduction, reduction in hypertension, reduction in type 2 diabetes and 8 types of cancer, improvement in depression and cognitive function, reduction in the risk of dementia, improvement in quality of life and quality of sleep, and improved weight status. And then looking for older adults, we're looking at reduction in falls, reduction in frailty, and improvement in general overall physical function. So rehabilitation is not linear, and individually you need to set specific, individual SMART goals. Prescription must be adapted to meet the challenges and the requirements for the function and the well-being of that individual. Not everyone is the same. Not everyone can make the same leap towards physical activity. And for most people, or most of the patients that you will come across, making that first initial leap can be really quite tricky. So education is key. When we're describing the intensity of exercise, we're looking from sedentary all the way through up to very vigorous exercise and thinking about how that may impact your patient. So think about the impact on the heart rate, respiratory rate, and also on energy consumption. For somebody that's not moving or works at a desk, their heart rate is low, their respiratory rate is affected and is low, and they're using very little energy. People doing light exercise, so things like cleaning, carrying out rubbish, yoga, slight increase in heart rate, slight increase in respiratory rate, and overall energy consumption is moderate. Thinking about doing moderate exercise, walking, cycling, shopping, again, improving that heart rate, increasing that respiratory rate, and also improving energy consumption. Vigorous or very vigorous exercise, we're looking at an exponential increase in terms of heart rate and respiratory rate, but also improving function of the heart and improving function of the respiratory system. So when we're talking about patients and exercise prescription, we're thinking about analysing that patient's needs. So what is the task and what are the challenges of it? what energy systems are required for the task. Does our patient have any requirements of those energy systems that are going to be impeded by the task? What planes of movement and axes does the function occur around? And what body segments and joints are being involved? What type of muscle work is required? Is it going to be isometric, isotonic, concentric or eccentric? And in what range are we going to be asking them to work, within inner, middle or outer range? What is the normal speed required for the action? Can we accelerate it? Can we decelerate it, depending on how our patient responds to it or how easy or difficult they find it? And what kind of sensory motor requirements are required? Do they need to be able to have good sensory motor function to be able to perform the task that we are asking of them? So conditioning efficacy. Conditioning efficacy is the ability to achieve the performance or rehabilitation outcomes through the programme that we've provided. So we're making sure that we have a structured approach which will improve the chances of optimal recovery. We've planned and designed a programme with aims and outcomes, and that's timetabled to progress over time with different focus at different times. So whether we're focusing on the cardiovascular function or strength or flexibility at different times throughout that timetable. We're looking at the basic principles that drive the adaptation to exercise. So thinking about neuromuscular changes, thinking about cardiovascular changes. We understand the end goal. What are we trying to get our patients to achieve? What are we hoping to achieve for our patients? And thinking about the threats and to conditioning. So they're thinking about rest and recovery. What might happen if we don't introduce enough rest or recovery? Are we going to cause undue injury to our patients? So movement for function, a movement that achieves the function for what is intended, regardless of the quality and energy expenditure. And functional movements are movements that are based on real world situational biomechanics, things like sit to stand, climbing the stairs, thinking about lunges, thinking about getting in and out of chairs. Function, we're thinking about platform, the balance, the support that the patient might need, how they're going to absorb the force or produce the force to be able to stand up or sit down or to be able to walk. Thinking about weight transference, so it's something as simple as being able to walk to the end of the room. You're thinking about patient being able to transfer weight, being able to transmit force to be able to drive themselves forwards. Are they able to stabilize effectively? So for a short time when you're walking, you're stood on one leg. So do they have the stability around that leg, around the hip, around the knee, to be able to produce effective movement? Are they able to accelerate or decelerate effectively? And do they have the correct timing and coordination or proprioception to be able to perform that function effectively? So functional exercise should attempt to involve as many elements as possible. So things like balance, multiple joints, and lots of different planes of movement. Decreasing the load on the muscle and increasing the difficulty of motor coordination or muscle synergy and flexibility. So normal movement should be smooth, coordinated, well-timed and effortless. And that was suggested by Bo Bath, who works really closely with neuromuscular problems and is especially prevalent within paediatric neurological physiotherapy. Assessment of needs should identify where loads occurring, looking at functional movement testing aims to identify any weak links or energy leaks, thinking about the chronicity of symptoms and is it linked with dysfunction? So if somebody has a chronic back problem, is that because they're continually moving dysfunctionally? And is there a link between deficiency and deep local stability of muscles? And does that have a direct link to patients' pain or recurrence of injury? So connective tissue changes with abnormal use. So if you're using your connective tissue abnormally, you're going to end up with a random pattern of collagen. So restriction of expansion and contraction of muscles. You get less crimping, so tightness and elongation. Reduced elasticity of tendons, so cyclical movement may become more energy expensive, making it more difficult to perform the task. Reduced angle of pennation, so change in energy transmission through the aponeurosis and the tendons. And lack of extensibility, so minimal contraction forces, which may cause immediate movement. Normal activation of muscles should allow for resetting of the muscle spindle, giving enhanced feedback. Postural muscles should be able to work isometrically, isotonically, and sustain contraction. And also muscle movement should be faster and through a wider range of forces and movement. So when we look at facilitating movement, as physiotherapists. The law of facilitation suggests that when an impulse is passed through a certain set of neurons to the exclusion of others, it will tend to take the same course on future occasions. And each time that impulse transverses its path, on all future occasions, the resistance is less. So if you have a repeated impulse passing through the same thing over and over again, the chances are that on the future occasions of those impulses passing through, the resistance to that impulse will be much less. So sensory systems gives a frame of reference for body positioning, motor response, and needs to adjust if appropriate. So can you adjust joint mechanoreceptors, vestibular, visual symptoms, visual cues? So can you close somebody's eyes? Can you open somebody's eyes? Can you do something as simple as putting glasses on somebody that has issues with short-sightedness or long-sightedness? Are there issues with proprioception in the ankle joint itself? So does there need to be work done around proprioception? So moving on to proprioceptors. The idea of muscle proprioceptors is that they respond to change in length of contraction of the agonist. So more than half of the innervation to a muscle conveys information to and from the muscle spindle and is the body's primary source of proprioception. The Golgi tendon organ responds to that tension and then has an autogenic inhibition of the agonist. This concept together produces proprioception. It might be worth just pausing that here and getting your head around what proprioception means. In order to optimize the function of the body, we must recognize muscle synergies and train movements and not muscles. We must recognize that we are training connectivity through unity in movement and that it is integrated and not isolated. We should be looking at resistance training throughout the body, thinking about key physiological benefits, thinking about how can I help manage and treat my conditions, and is training effective?